Welcome back to the Just Hard podcast, where we break down nursing concepts that make you want to close your textbook and take a nap.
I'm Chelsea.
And I'm Lisa. Today we're talking about cancer treatment modalities, surgery, radiation, chemotherapy, and all the words that sound like they mean the same thing but definitely don't.
Like adjuvant and neoadjuvant. If you've ever read those words and thought, wait, what's the difference again? This episode is for you.
We're also going to talk about why treatments are chosen, what nurses need to monitor, and yes, we've got some ridiculous commercials in here too.
Because if we don't laugh, we'll cry. Let's go.
Let's do this thing. Okay. So let's talk about cancer treatment modalities. Usually cancer treatment falls into a few main categories: surgery, radiation, chemotherapy. Those are the top three. Then there's immunotherapy, hormone therapy, and targeted therapy. Today we're focusing on the big three: surgery, radiation, and chemo, because those are the ones you'll see most often in the clinical setting.
And the key thing to understand is that these treatments are often used together. It's not usually just one or the other.
Right. A patient might have surgery to remove a tumor, then get chemo to kill any remaining cancer cells, then radiation to target a specific area. That's called multimodal therapy.
And that's where adjuvant and neoadjuvant comes in. Those terms have always been so confusing to me, but you really do need to know them, because when you read your oncologist progress notes, you will see that they use that terminology.
And I thought it was just kind of a textbook thing. I didn't realize it was really real.
Yeah, but they do show up in the notes.
Then I got a real job, and I was like, oh, dang, there it is.
Yep. So those terms they help describe when the treatment happens in relation to surgery.
Okay, let's break this down. Adjuvant therapy is treatment given after the primary treatment, usually surgery. Adjuvant for after, to reduce the risk of recurrence.
So like after adjuvant therapy.
Yeah.
So if a patient has a tumor surgically removed and then they get chemo or radiation afterwards, that's adjuvant therapy.
Exactly. The goal is to mop up any microscopic cancer cells that might be left behind.
Think of it like this. The surgeon got the big stuff, but adjuvant therapy is the cleanup crew.
Perfect analogy. Now, neoadjuvant therapy is treatment given before surgery.
Wait, why would you treat before you remove the tumor?
Great question, Chelsea. Neoadjuvant therapy, man, say that 10 times fast when you need a drink of water, is used to shrink the tumor, making it easier to remove. It can also help determine how well the cancer responds to treatment.
So it's like softening the target before you go in. I would say that I probably most commonly see this with brain cancers.
Exactly. Yep.
They go in, they do radiation, try to decrease that size before they go in and debulk it.
It's also common in breast, esophageal, and rectal cancers. Yeah.
All right, so to recap, neoadjuvant is treatment before surgery to shrink the tumor. Adjuvant is treatment after surgery to kill leftover cells.
Bingo. And on the NCLEX, they love to test whether you know the difference.
Let's talk about surgery. So this is often the first-line treatment for solid tumors, right?
Yeah, if the cancer is localized and hasn't spread, surgery can be curative, meaning it removes all the cancer.
And this part has always just thrown me for a curveball, that cancer is so painful and obstructive that surgery can actually be palliative. Like, on what planet is surgery for comfort enhancement?
Right.
Only with cancers, right? So it relieves symptoms, not cure the disease. An example of that, actually, I had a lady that had a palliative. She had a colostomy created to bypass the colon tumor obstruction before she went home on hospice.
Yeah, so like for her, the tumor was blocking her bowel or causing pain. So even if they couldn't remove all the cancer, there she gets this colostomy. That's awesome.
Yeah, and so that's kind of like debulking too. So you remove as much of the tumor as possible, even if you can't get it all.
Yeah, that's a common in ovarian cancer. My grandma actually had that. The goal is to reduce the tumor burden so that the chemo or the radiation actually can work better.
So as a nurse, what do we need to watch for post-op?
Standard surgical stuff, infection, bleeding, pain management, but we also want to watch for signs of metastasis. So if the margins weren't clear, meaning they didn't get it all, then it might metastasize.
Yeah, so they call that clean borders, right? They want to go in and they want to cut away you don't want to cut straight through the cancer cells and leave some in there. You want to get a clean border with all of those cells that are well differentiated remaining.
Correct.
Right.
Yes.
So that that you hopefully got all of those cells.
Yeah. Yeah. And what about their emotions? Like, a lot of patients feel like surgery should have been fixed and done everything. When it's hard when it doesn't.
Yeah, absolutely. Surgery is a big deal physically and emotionally. That's why it's so hard sometimes for me to fathom the fact that it's palliative for these patients.
Right. That's so true. Chelsea, let's take a commercial break.
All right.
All right, tired of your tumor taking up too much space? Introducing Debulk Max, the only surgical solution that says we'll take most of it.
Debulk Max, because sometimes good enough is good enough.
Side effects may include relief, reduced tumor burden, and the lingering question, but did they get it all?
Debulk Max, shrinking your problems one tumor at a time.
Debulk Max, we got most of it.
All right. Welcome back to Just Hard. Let's talk radiation. This one scares a lot of students.
It doesn't have to. Radiation uses high energy waves to kill cancer cells or shrink tumors. It can be curative or palliative.
And it's localized, right?
It targets a specific area, like chemo, which is systemic. Radiation is aimed at a particular spot, like the breast, brain, or lung, unlike chemo.
Right?
I'm sorry,
So chemo is systemic. So radiation can be localized. So that external beam radiation, if we're doing external beam radiation, it's only affecting the areas that hit the beam. But you have to remember that that's not just the cancer cells. It's affecting whatever other organs, tissues, structures that beam is going through.
Yeah. Brachytherapy is where we implant it. Like that internal stuff. But external beam, that's what most people think of. You lie on a table, a machine delivers the radiation from outside the body.
And then brachytherapy or brachytherapy is internal. So the radioactive material is placed inside or very close to the tumor.
Yeah, that's common in prostate cancer. We see that a lot.
Yes.
Prostate seeds, and cervical cancer.
So what do we need to teach the patients?
Skincare is huge. The radiated area can become red, dry, and irritated, really like a sunburn.
So that's for your external beam.
Yeah, it is burning them. Yeah, so we want to tell them to use gentle, fragrance-free moisturizers. So you do want to keep it moist. Not moist, but like moisturized.
Hydrated.
There you go. There you go. Avoid tight-fitting clothing over the area. No sun exposure. No heating pads or ice packs
because that'll make the burn worse.
That tissue damage. Yeah.
And then fatigue, that's a huge one with all forms of radiation. A lot of times people don't understand how tired radiation makes you, especially that external beam, but your body's trying to heal and the cells are turning over and
you just think a lot of people think of radiation like, well, I got radiation when I got a chest x-ray. They just took my picture and I didn't get tired after that.
Yeah,
this is different.
Yeah, this is exhausting.
Yeah. Encourage your patient to rest, hydrate, and eat well.
And then one other key note, if they do have that brachytherapy, that internal radiation, depending on what type it is, the patient could potentially be radioactive for a short period of time. So we have special precautions, right?
Yeah, they got to follow the isolation precautions, limit their visitor time, and maintain a distance. Yeah.
During that time.
Another thing, too, is if they do have that external beam, sometimes they'll put markers on the skin. Don't wipe those off.
Yes.
Oh, my God. Don't clean that off. It's not like the little stamp from the bar that you want to wipe off so no one knows. Leave it there. Don't touch it because that tells the technologist where to aim the beam.
Right. Yeah. Okay.
Yeah. Missed it because you washed your skin.
Darn it.
Yeah.
Let's have another commercial break.
Feeling burned out, literally? Introducing Radioglow Skin Soother, the only lotion designed for post-radiation skin that looks like it spent too long at the beach.
Made with aloe, no fragrance, and zero judgment.
Radioglow, because your skin didn't ask for this.
Radioglow, gentle care for when your cells have been through enough.
Radioglow, soothe the burn, not the hope. All right, now let's talk about chemotherapy, the treatment that kills fast-growing cells.
Which includes cancer cells. Obviously, that's what we're trying to kill. But it also kills your normal cells that are rapidly dividing. It targets rapidly dividing cells. So hair follicles, GI lining, the mucosa, and bone marrow cells.
Right. That's why chemo has so many side effects.
The most common ones students need to know. Myelosuppression. I can't tell you how many students kept getting my quiz or exam questions wrong because they could not remember what myelosuppression meant.
Right.
The terminology. So myelo, think bone marrow.
Yep.
So bone marrow suppression, you're going to see low blood counts.
All of them.
Yeah. Right. So neutropenia, what's that one, Lisa? Let's go through what those
my neutrophils, low.
Okay.
Yeah.
Thrombocytopenia.
Yeah. Platelets.
All right.
Yeah.
What's the other one?
Anemias, hemoglobin, hematocrit.
Okay.
Yeah.
I feel like there's one more. Neutropenia, thrombocytopenia.
Brain fart. I got it. I don't got it.
I don't got it either.
Yeah. Somebody email us.
Well, those are obviously the ones that we're going to be thinking about.
Exactly.
For our,
Yeah, right? Yeah.
Yeah. So myelosuppression. Think bone marrow. Wait, we said thrombocytopenia.
Yeah, we did that.
Leukopenia. Neutropenia.
We're awesome.
All the penia. Penia means low.
Yeah, we're awesome.
Yeah.
We're amazing. Yes. Yeah.
Okay, nausea and vomiting.
Yeah, that's the whole effect of the GI tract, right?
Right.
Everyone thinks that it's not actually caused by the chemo. It's because of the side effect of the chemo. Yeah.
Mm-hmm.
Yeah.
Mucositis or mouth sores. They can get stomatitis, ulcerations in their mouth and their esophagus. That's very painful. Alopecia, meaning hair loss, baldness, and of course fatigue.
Yeah. Yeah. Okay. So let's talk a little bit more about those penias, right? So myelosuppression, because that's really the most dangerous.
Right.
I mean,
the others are uncomfortable.
yeah,
They
it sucks. It sucks you lost your hair. I'm sorry, but bald is beautiful. Speaking as the wife of a bald man. Bald is beautiful.
I've seen some cancer patients rock their bald.
Seriously.
Mm-hmm.
Yeah. Yeah. I mean, what are the other side? I mean, I get it. If you're living through it, I hear you. I sympathize with you. I get
nurse,
it. You ain't gonna die from being bald.
Yeah. So we need to be worried about the things that are going to kill our patients. So neutropenia, low white blood cells. Think infection risk, right? That's why they don't get fresh flowers.
Yeah.
They don't get fresh fruit. They get things that are canned and processed if they're on neutropenic precautions because they've got no immune system.
Yeah.
So you better not be coming to work sick and taking care of a cancer patient. And you better be washing your hands when you go in and out of that room because you could kill them.
Yeah.
Yeah.
For real. Like hand washing is so overlooked and underrated. It is a life-saving thing.
Yeah.
Yeah.
And then they can still have visitors. Like they don't have to live in complete and total isolation, but you don't want like kids crawling on the floor and people coming in that are sick. Like don't come in if you're sick. So so we're worried. We need to prevent infection at all costs. And it sucks because now they've got lines. These patients probably have lines that are a portal for infection.
And then we get blamed. We get blamed from the lines getting infected.
Right. They've got zero immune system.
Yeah, when some 2-year-old toddler's crawling all over them. Yeah.
Anemia. So we hit on that briefly. Low red blood cells. So fatigue, hypoxia. Red blood cells, your hemoglobin, it carries the oxygen. It enhances oxygen delivery. If you don't have enough blood to carry the oxygen, the tissues are going to die.
Yep. If there's no taxis in New York, you're not going to go see the Statue of Liberty.
Oh, yeah, that's true.
Yep.
Mm-hmm.
Not going to get
And
there.
then there's thrombocytopenia, so low platelets, so risk for bleeding.
Yep. No clotters.
Yep, and sometimes they're always thrombocytopenic, right? We don't always transfuse for thrombocytopenia.
Correct.
Unless it's below like a certain number for that particular patient because they're always there, right? Mm-hmm.
Yeah, and we might hold like Lovenox, like if it's less than 100, we might hold that we don't need to give them any more. But yeah, for sure.
So my patient's platelet count might be like 50. I could potentially still insert like a Foley catheter if there's an order. It's not an absolute contraindication, but I would probably clarify with the provider, hey, are you sure? Like an NG tube? I would hate to do that.
Oh, let's talk about that. I got a story. Story time with Lisa.
All right.
Okay, so we had a patient come into the ER one time that had a stroke, and onset was like they were talking to someone and then all of a sudden started slurring and having facial droop and arm drift. So immediately came in, they were right in the window, so we gave them a clot buster, T&K, Alteplase. We gave them, I can't remember the brand. We gave them something fabulous.
Right.
Broke down the clots, right? So they're admitted, they're hanging out in the ER, and because they were slurred, they couldn't swallow. So they couldn't swallow. So we gave them the meds to break down the clot. The night shift nurse came in. I believe he was a traveler, and I love travelers. Like, this is not a knock on travelers.
Yeah, I
this
was a
is
traveler
not
for 5 years.
Yeah, this is not a knock on travelers. But I believe he was a traveler, and I gave report. In the night, he decided he was going to put an NG tube in this patient because they couldn't swallow.
Oh, no.
I came in, patient was still there because, impacted ERs. Patient's still there, massive blood loss through the mouth because when he put the NG tube in, he nicked some vessels, which happens. You get a little bit of nose bleeding sometimes. Yeah. We had to call ENT to come in because the patient is aspirating on their own blood. I was pissed.
Nurses,
use your brain.
Think about what you're doing. Does it make sense? Why are you doing it? I always say don't blindly follow orders.
Right.
How many times has a doctor given you an order when they've been on call all night and you call them at 7 a.m. and they're half asleep still and you're like, wait a minute. Like they're not, you don't blindly follow orders. You need to think about what you're doing.
Just like I am human, providers are human, and we're a team. Like, I got
Yeah.
your back, you got my back. Let's
Yep.
think through this.
Yeah,
Exactly.
yeah. So I don't ever
well
want to hear
stated.
when I ask, why are you doing this? Oh, because the provider ordered it. That
Yeah.
is not appropriate.
Yeah, you deserve to be throat punched if you say
Yep.
that.
Yeah.
Yeah,
So,
that's not
yeah,
how
so that's
we
a
roll.
big takeaway from that.
Yeah.
And then so bleeding risk. So platelets less than, is it less than 20,000? Their risk for like spontaneous.
Oh yeah, I thought it was like
a
40, but
spontaneous
yeah.
stroke. Yeah. So there's different numbers. So
Right.
sometimes we are going to transfuse them, but they might be living in the 40s, 50s.
Yeah.
You know, for
Yeah.
a while. But
Yeah, they may have a different
Clarify.
disease too.
Yeah.
That might cause that too. Yeah.
Mhm.
So nadir, that's an interesting word. It's the lowest point, usually 7 to 14 days after treatment.
So that's when they're most vulnerable.
Yes, yes. So nursing interventions, we would monitor the CBC closely. Here's a trick to that too, right?
The nadir is related to the white count, though,
Correct.
right? Yeah, the
Yeah.
white count, the lowest point of the white count.
Yeah, so when we're drawing the CBC, if they're anemic, meaning they have low H&H, that's what anemia means. Anemia means low H&H. We got to figure out why, right? We are smart. We know it's chemo related. We know that
Bone
that
marrow
it's low.
suppression. Yep.
So if they're anemic, we don't want to draw large volumes of blood for our
Thank
CBC.
you.
Let's get pediatric tubes.
tubes.
Let's get neonate tubes. They can run a CBC on a neonate with a small volume. They can run a CBC on a human, on an adult with small volumes.
You know who
So
else I
use
do
your
that
brain.
for? Patients that are religious beliefs, Jehovah's Witness, that will not accept a
Exactly.
blood transfusion. I don't even care if they come in with a hemoglobin of 10. I'm using pediatric tubes
Yes.
because in case they bleed, they need to hold on to all the blood that they had.
Nursing pearls from Lisa and Chelsea.
That's right.
Exactly.
All
So
right.
monitor their CBC, teach neutropenic precautions, hand washing, avoid crowds, no raw foods. Monitor for signs of infection. We know these. Fever is an emergency in a neutropenic patient. This is an emergency. So administer colony stimulating factors like filgrastim. I always study over
Neupogens
that.
that use your, but
Exactly.
yeah,
I know.
NCLEX, it'll say filgrastim
I know.
or
We're probably going
Neupogen.
to get sued for using a brand name, but
I
get
don't
over it.
know. Maybe we'll get promoted and
Someone will
sponsor.
pay for our podcast.
Yes.
Please feel free. Send us money.
I
coffee
actually,
cards.
okay, we're going off on a lot of
Cash
tangents
out.
on this
Oh, yes.
episode,
Okay,
but
that's
very
okay.
quickly.
That's okay.
When I was after high school, when I was 19, I moved to Illinois with my first husband. He was military, so we were stationed out of Waukegan. And I've only had two, by the way, one per decade. So the first husband, so we were in Waukegan, Illinois, right? Well, when I was in high school, I donated blood, which I can't donate blood because I faint. I can't stand the sight of my own blood. They have to put me in Trendelenburg, put the fan on me.
Okay.
Every time I've tried
Contraindicated.
it, I
Okay.
can't do it.
Can't do
So I have to serve in other ways.
Okay.
Yeah. So anyways, they said, would you donate? And they said, do you want to be on the stem cell bone marrow registry thing? And I was like, sure, why not? Well, a year later, I'm living in Illinois, and I get a phone call from the National Marrow Donor Program, and they're like, you're a match. And they flew me down to Florida because that's
Wow.
where I matched. So they flew me down to Florida. I stayed with some family down there. And they had a home health nurse come out every day for like 5 days and give me shots of Neupogen
I love it.
to stimulate my own cell release. And then I went and I did the donation of the stem cells where they take it
So
out. And it's like kind of like dialysis. Is it plasmapheresis?
Probably.
Is it the same thing? But yeah,
Very
because I didn't
similar.
know. I wasn't a nurse
Yeah.
yet. I didn't
Sure,
care.
of course.
I was a waitress. I was a team lead at Chili's.
Yeah.
I was good at it too.
Atta
It was
girl.
fun.
Atta
Yeah.
girl. Yeah.
Right, would you like a presidente?
Waitresses make great nurses. You can multitask.
I know.
I love it.
I loved waitressing. I
Yeah.
thought it was fun.
So let's talk about the stem cell
Oh, yeah.
recovery. So it was really like a blood draw.
Yeah,
Yeah.
yeah, it was. So I went 2 days in a row, and they did pretty much the blood draw. You sit there for like 3 or 4 hours, just
Yeah,
kind of
kinda
like
like-
a dialysis treatment.
Yeah.
Yeah, they
Kind of like a long blood donation.
Yep.
Yeah.
And then I remember though the guy told me that 6 out of 6 of my HLAs were a match, and he said you have a greater chance of winning the lottery or getting struck by lightning.
Wow.
And they said I think it was after 1 year or 3 years, you could call to find out what happened to the patient.
That's cool.
I never called.
Oh,
I know I'm such a
Chels.
slacker
Someone's
sometimes.
alive today because of you.
Maybe.
They are.
Maybe.
Or they got hit by a car afterwards. but
Yeah, you know, life
Whatever.
has
Right.
throw some damn curveballs, huh?
No kidding.
Yeah, but that's what I always think about with the Neupogen. So we can do it for things like that too, but colonnading stimulating factors, it just makes your bone marrow release more of those cells into the bloodstream.
That is so cool.
Yeah.
That is so cool. So the last intervention I can think of right now is just like think about bleeding precautions. If their platelets are low, think about that.
Students
Yeah.
love soft toothbrushes. Just because you see a soft toothbrush, it may or may not be the answer.
Right.
It's not always
I
a soft toothbrush.
Isn't that the truth? Yeah.
And then,
Yeah.
of course, comfort measures like antiemetics, give them before you
no
start
kidding.
the chemo.
Once your patient's puking, it's too late, sister.
Yeah.
Yeah.
So
Yeah.
prevention is key.
For sure.
All right, let's have another quick commercial break.
Okay. Have you or your loved one been affected by chemo brain?
You may be entitled to absolutely nothing because it's a real side effect and we're all just doing our best.
Symptoms include forgetting why you walked into a room, calling your dog by your kid's name, and wondering if you already took your meds.
Chemo brain. It's not you, it's the cytotoxic agents.
Chemo brain.
Wait, what were we talking about?
That's awesome. Oh.
All right, let's talk about immunotherapy, targeted therapy, and hormonal therapy. Just a brief overview. We should at least mention these, even though they're not the main focus today.
Agreed. Immunotherapy helps the body's immune system recognize and attack cancer cells.
So examples, checkpoint inhibitors like pembrolizumab or Keytruda.
Yeah, that one. The MABs are hard for
The
me to
MABs.
say.
The
Oh,
MABs
my
are your
goodness.
immunotherapy ones.
Yeah. Then there's targeted therapy that attacks specific molecules or pathways within the cancer cells. It's more precise than chemo. Very specific.
Examples, trastuzumab or Herceptin for HER2 positive breast cancer. Sounds like we're doing another commercial.
Boy, no kidding, right? Then there's hormone therapy. Hormonal therapy blocks hormones that fuel certain cancers. We know that hormones are a risk factor, so we can also use hormones to treat it, like breast and prostate cancer.
So wild, isn't it?
Yeah.
Especially when the cancer cells start creating their own hormones. That,
I know.
yeah.
Yeah.
The worst, I always think about the pancreatic. I had a guy with insulinomas, and it was secreting, the tumors were secreting their own insulin, and he was living on a D10 drip plus getting pushes of D50 because his body just said,
eat all the
"You're
candy
gonna
you
have."
want.
Yeah, exactly.
Eat
Couldn't
it
have
all.
enough. So hormonal therapy, examples, tamoxifen, aromatase inhibitors. So just immunotherapy, think the ones that end in MAB.
Yeah.
The MABs.
Yeah.
The ones that are hardest to say.
Exactly, yeah. You did a great job at pronouncing
Thanks,
those, by
yes.
the way. These are huge topics on their own, but for now, just know they exist and they're becoming more common.
Yeah, that's why oncology is a specialty, right? Like I couldn't tell you the names of many of these drugs. I do tamoxifen, I recognize that. There's a few that I recognize that are more common, but that's why it's a specialty.
Exactly.
And you have to be certified to administer chemotherapy. It's
You
not
sure do.
like everybody's just going to go in. You know, induction of chemo is a big deal.
It's a big deal, and most patients are going to do great, but that's why you have to be certified because there are complications, there are side effects, and you need to be aware of those.
Yeah, like tumor lysis syndrome. If I'm
Exactly.
inducing chemo, that would be something I would be anticipating.
Exactly, yeah.
So putting it all together, let's say that you have a patient and they just got diagnosed with stage 2 breast cancer. What might their treatment look like?
Yeah, great example. So they might get neoadjuvant therapy, chemotherapy to shrink the tumor, surgery, a lumpectomy or a mastectomy, adjuvant radiation to the breast or the chest wall, and then adjuvant hormone therapy. So if it's hormone receptor positive, then we might give them a hormone to help treat that.
Yeah, so the pieces all fit together. So we need to be able to understand what our patient is receiving. I might not need to know the name of the, I kind of want to know some of those side effects. They can cause dysrhythmias, the common side effects, the big ones, but I need to know, collectively what kind of treatments is my patient on, so I know how to take care of them as a whole person and for looking for those complications.
Yeah. So that's why understanding the terminology matters. You need to know what's happening and why. So thanks again, Chelsea, for another great podcast. So this was great. All right.
Yeah, we'll see you next time.
All right. Don't forget,
Yep,
it's
it's
just
just
hard
hard.
and we can do hard things.